For a patient to meet criteria for schizophrenia, they must have at least 6 months of impairment of social, occupational, or personal function, as well as more than 1 month or less if the patient received treatment of at least 2 symptoms, including delusions, hallucinations, disorganized speech, disorganized behavior, and negative symptoms. At least one of the symptoms present must be delusions, hallucinations, or disorganized speech. Schizoaffective disorder, depressive disorders with psychotic features, and bipolar disorder must be ruled out, and the disturbance cannot be due to substances or another medical condition. One way to distinguish drug-induced psychosis from schizophrenia, if drug-induced psychosis is high on your differential, is to see if a patient reconstitutes without initiation of antipsychotic medication. However, some symptoms of drug-induced psychosis, such as paranoia or other delusions, may also last long after discontinuation of the specific substance, so it can sometimes be difficult to distinguish with full certainty. Historically, autism was confused with schizophrenia. In a patient with a history of autism disorder or communication disorder, psychosis must be a prominent symptom. Useful specifiers include childhood onset, which means the patient meets criteria under the age of 13, early onset, which means the patient meets criteria prior to age 18. We can also specify severity. Each symptom is rated on a 5-point scale, ranging from 0 to 4, with 0 meaning the symptom is not present and 4 meaning the symptom is severe. The with catatonia specifier means patient also meets criteria for catatonia. Specifiers are also used to describe the onset and course of schizophrenia. For example, regarding onset, we can describe it as first episode, multiple episodes, or continuous. We can also describe if they are in an acute episode, partial remission, or full remission. If unable to specify due to lack of information regarding previous episodes, you may choose to use the unspecified specifier.
Let's talk a little bit more about the symptomatology in schizophrenia. Delusions are defined as fixed, false beliefs that cannot be changed despite evidence to the contrary. They must be out of keeping with the patient's social, educational, and cultural background. On the other hand, hallucinations are a perceptual disturbance without external stimuli. There are many different types of hallucinations and delusions that are not discussed in detail here, but one thing to note is that auditory hallucinations are the most common type of hallucination in patients with schizophrenia. Both delusions and hallucinations are characterized as positive symptoms because they describe additional experiences that the patient is involved in. Disorganized speech is discussed in more detail in the mental status examination videos of this boot camp, as it's important to document these findings in the speech and thought process sections of the mental status examination. In terms of grossly disorganized behavior, think about if the patient's behavior is difficult to follow. As an example from a real patient case, a patient may try to place a bar of soap into their ears or walk around naked in the streets without any clear indication. In order for a patient to qualify for the catatonia specifier of schizophrenia, they must have at least 3 of the 12 symptoms from the catatonia criteria, which are not discussed here. The patient may also have difficulties with activities of daily living due to disorganized or catatonic behavior. Negative symptoms in schizophrenia are defined as the absence or loss of normal emotional and behavioral experiences. These can include avolition, which means lack of motivation. Patients may have no motivation to go out, meet with friends, or even take their medications. They may also exhibit a flat affect. In contrast to a restricted or blunted affect, where the patient is able to display some emotional expression, a patient with a flat affect has no emotional range observable by others at all. Now that you know the criteria for schizophrenia, you may be wondering, how do I figure out if a patient is experiencing hallucinations or delusions? This is where the psychiatric interview, observation of the patient's behavior, and collateral information is important. Below are some questions you might consider asking a patient to evaluate for hallucinations. You can ask the patient what the voices are specifically saying and if the voices ever tell the patient to do anything, such as hurt themselves or others. It can also be important to try to understand how the voices make the patient feel. For example, hallucinations may be extremely distressing and anxiety-provoking for some patients. Persecutory delusions are a common type of delusion in patients with schizophrenia. So here are some questions you might ask a patient to evaluate for this specific type of delusion. Patients may be hesitant to discuss their delusions because of past responses from others, so it's important to be as non-judgmental as possible. A patient might ask you things such as, "Don't you believe me that this is really happening?" In this case, it's important to not support the delusion, but rather to explore how these thoughts make the patient feel and show interest in how these beliefs have impacted the patient's life, especially early on when the patient-physician relationship is still being established.
Malingering is when a patient intentionally exaggerates or fakes symptoms for secondary gain. It is important to identify a motive. When suspecting malingering, ask open-ended questions and look for both internal and external consistency. Ask about unlikely hallucinations, such as, do you see the words written in the air when you hear the voices, or are the objects you see in black and white? Clinical signs indicative of malingering are excessive hesitance or guarding when answering or frequently replying, "I don't know." Patients can be overly defensive, hostile, or intimidating to deter the interviewer from delving further into their falsified symptoms. Some answers may be overly dramatic in an attempt to convince you of their severity. Be on the lookout for unusual delusions, abrupt onset or termination of symptoms, or bizarre thought content without disorganization. Some extremely unusual hallucinations that are more likely to be due to malingering are continuous, vague, or inaudible voices without other psychotic symptoms.